So hello everybody, thank you all for coming. We're getting down to the home stretch here. This session's really an opportunity for you all to ask any questions that you may have after the course of this very long day, information-filled day. We're very pleased to have Dr. Kamiko Demoto-Riley from University of Washington, and Marianne Sanders from University Hospitals Cleveland. And if you want to just raise your hand, Deborah's got a mic. She can come over with the mic. And if you have a question, if you want to write down your question, just hand it to Deborah, and we can do it that way. So I'll turn it over to you.
So hi, everybody. I'm Dr. Demoto-Riley. I'm a neurologist up in Seattle. And I see, again, some familiar faces here, which is great. And yeah, we're just here to answer questions. And yeah, feel free to also write it down. We'll take it however you want to give it to us.
That's right. Hi, I am a nurse. I work in Cleveland, Ohio at University Hospitals Medical Center. I do work on clinical trials. I teach a caregiver education series, but I'm most grateful for my role as a support group, FTD support group facilitator. So welcome, and please ask us anything you like. Well, not anything, but.
Well, I'll start. We were just in a different session, and somebody had a question about muscle weakness and other physical symptoms and how to figure out what's causing them. Do you have any suggestions of how people could start investigating that?
Yeah, that's a great question. I guess maybe is it okay if I maybe broaden it to think about like motor symptoms? So yeah, we talk about, okay, there are cognitive symptoms, behavioral symptoms, and then there are motor symptoms, and that's, oh, okay, yeah, how about now? And motor symptoms are pretty broad. So one can be Parkinsonism. It doesn't mean that you have Parkinson's disease, but there are symptoms that look like Parkinson's. So that can be a tremor, but it can also be slowness of movement. And so it can be sort of a general feeling of weakness, but more slowing down of walking and shuffling. There can also be weakness, and with that we think about a different neurologic disorder, ALS or Lou Gehrig's disease. And that we can also see with FTD. And what often goes along with the weakness is sometimes then the muscles begin to get smaller, they atrophy, and there can be trembling of the muscles as well. So those are different types of motor symptoms that can go along with the cognitive and behavioral symptoms of FTD. Yeah, so this is why it is important to continue to have. The question was, well, how do you figure out what it is? And so that's why usually the team that's taking care of you wants to keep seeing you. So even if you say, okay, here's a diagnosis, that's all the more important that usually every 6 months or so, you would check in and have a conversation. And if there was something that was worrying you, like you notice my foot seems to be weak, then they can do an evaluation at that point. But that's why another important part of diagnosis is actually continuing to work with you over time.
Continuing on that thread, because I asked the question in the earlier group, is there anything you can do when muscles start to atrophy? That's what we're talking about, right, is atrophy. Is there anything that one can do? I mean, if you're exercising and you're eating right, is this something that it's just going to progress and that's just life?
So I guess one of the complicated things we keep coming back to is what is causing that. If at some point there is a thought that ALS is contributing to the symptoms, there are actually some medications for ALS. And so that would be, a change in terms of treatment. And then another part would be that exercise. We've been talking about how important that is to make sure that the exercise is safe. And so that those recommendations might change depending on the physical symptoms.
I have a question. Actually, two. The first question is, if we are trying to explain what's wrong with ourselves, are we better off using the term dementia or using the AFTD term?
You know, I think it depends on what you're most comfortable with, honestly, because I think either one of those terms describe sort of the same thing. So dementia has a real stigma attached to it, and people oftentimes struggle with that. So degeneration, frontotemporal degeneration is fine. Is that what you're comfortable with?
Because during the conference, even,
Right.
you go back and forth, and
Right.
years ago, when the name change came about, it was for a purpose, and I didn't know, is there now a turn to going back to using the
You know what? I don't think so, and you can tell me if you think this is correct or not. I think that it evolved to degeneration, frontotemporal degeneration, but people that were used to saying frontotemporal dementia just continue to use that, because even myself, I go back and forth. I try to correct myself, but FTD. My old self.
That's a problem. I've had numerous surgeries on my eyes. And one case, we just said I had a brain disease, but it was fine to do. Other time we said I had FTD. They go, what is it? And they put down dementia. I got treated totally different because the big D word changed the attitude. And I just would like to see us have some continuity for new people getting it.
Yeah.
Because unfortunately, in the medical world, they hear the word dementia. We should be drooling and wetting our pants.
Yeah. Yeah, I'm so sorry, that's been your experience. I really am. It shouldn't be. And really, nobody, even if they have a diagnosis of dementia, of any sort of dementia, should be treated in a disrespectful way, period.
Well, part of BV, you do have a more direct way of dealing with people, your filters. As I've been told many times, well, you don't look sick.
Yeah.
Right, that's another thing. Right.
But I like the comments today we got to before to that.
Good.
Question about treatment options. So my background is I'm a nurse practitioner, diagnosed last year with atypical behavioral variant, FTD. So I've transitioned from provider to patient in the past year. And of course, as a provider, I'm always looking for treatment. You always, and if you can't treat, you palliate well. And because I did palliative care, I don't want to be the one receiving palliative care. I want to be the one receiving treatment. And so on the horizon, I've been going to Dr. Beauvais at Mayo, and he's done every neurological and genetics test known to man, and that my insurance will cover up to the cost of like $30,000, and it's not genetic. So as of this time, there is no treatment, and that's really hard for my wife to hear. And for me, I'm sucking it up, but on the horizon with what you've seen in research for all of us here that are dealing with this and seeing, a prognosis that is, according to the books, terminal. And it's hard for us to hear that, whether it's terminal in 2 years, 10 years, 15, whatever. What do you see as treatment options for people who don't have a genetic variant for frontal temporal dementia? Is there anything out there that you're looking at besides behavior modification to help palliate our symptoms and make us nicer people and not be assholes. So, and really, do you have anything? Is there anything on the books out there that you're seeing?
Yeah, this is a hard question, and thank you for asking it. Yep. And I think also what even though we think about treatment in many different ways, I think we have to be careful to not look away from other types of treatment. So yes, all these different lifestyle behavioral modifications, they are treatments. So I think that's one thing that we have to keep reminding ourselves about. I think it can be frustrating. You were mentioning that there's a lot of interest right now with research interventions focused on individuals who carry these different gene changes. And that's because it can be so hard to diagnose FTD and specifically to know what the underlying protein tangle is. And if somebody is carrying a specific gene change, then we can be more sure about it. And so that's partly why in research there has been a focus on trials for people who have these different gene changes. However, at the same time, there is a lot of interest in trying to diagnose as early as possible and to quickly take the interventions for those who have the gene changes and translate that for other people who don't have it. And I think that was one of the encouraging findings so far in these big consortia is that we can pool a lot of this information, especially since you saw from Jamie's talk that most people do not have these gene changes. This is still a long way to get around to saying, well, we don't know right now. And one way I think about this is of being hopeful, which might not be the best way, but these drug companies remain very interested in FTD because it is a rare disease, and they are also interested because there is, for some approaches, if they help with a cure for FTD, they can get a blockbuster medication for Alzheimer's disease. So it remains very attractive, and so I think there is still a lot of hope that there will be something on the horizon soon. But what the research community has been very cautious about is to make sure that companies understand that FTD is different, and even just the basic measures that they've been trying to use to look at efficacy for Alzheimer's disease, they need to look at FTD a bit differently. So we're cautiously hopeful, and in the part about the genetics sometimes also gives us that extra window. For example, that's how cholesterol medications, which are almost in the drinking water, they were identified by working with families in Italy that had a rare mutation that caused very high cholesterol. And now those drugs are available to everyone. You don't have to have that gene change. So I think this hopefully will very quickly translate into opportunities for everyone.
When you say quickly, though, from the time that you get a drug company or whoever, anybody, gets something that looks promising and it's showing, by the time they get something that looks promising and it's getting through some initial tests, there's a time lag before this actually hits the real world, isn't there?
There is a time lag, and that's, again, where the interest in rare diseases becomes crucial because the FDA often fast tracks these types of approvals. So that's again why it's attractive. We do have to be careful though, and we keep thinking about research opportunities when an investigational drug is being administered. What we have to keep in mind is they are primarily looking at safety. Then they are looking to see if it's an effective drug. But that's the number one thing that is being evaluated. And in order to make these judgments, a certain portion of people in the trial are often given a placebo. And so I think while it's very exciting that there are these research opportunities, we have to be cautious that we don't know what will happen, that these are new drugs, and unfortunately there can be bad side effects in addition to the good parts that we're hoping for.
And just one quick note that I want to say is that these diseases are so complicated, and we do need to discover targets, and that's why being involved in Artful and Lefties and those kinds of programs right now, or studies, are so important. Looking at Alzheimer's disease or dementia trials, that type of dementia, we have tried so many studies. I mean, we at our center have probably been involved with 30 different compounds, and nothing has been seen as efficacious for 15 years. You know, so not that I want to kind of take all the hope out of the room, but it's just so complicated to find something that, you know, is at least when I'm talking about a medication. So.
I'm Deborah Niehoff. I'm the research manager at AFTD, and I want to add to all of that that there's also hope from non-pharmacological interventions, and there is research going on things like transcranial direct current stimulation, and we actually have a brand new pilot grant stream that is looking specifically at non-pharmacological interventions, so there's hope on that front as well.
I actually was just going to ask a question about the brain stimulation. Can you speak a little bit more about that? Like,
yeah, there's different types, and it's basically a non-invasive way. It often involves a magnet, but it's sort of tuned in a way that it affects so our brain runs on electricity, and so it adjusts the electrical currents in the brain. But there's many different variations, and there's different centers looking at this. For example, they've been looking at in people who've had a stroke, and then by extension, there's been groups looking at this in FTD. In Baltimore, there's been some work with people with PPA doing this type of brain stimulation, and I think at UPenn as well. There's been some work going on, and yeah, there are questions of, you know, how long are these effects there? It's exciting. It's exciting to think about, and. You know, for each study that happens, there are often things that they have to be careful about. So, for example, if somebody also has seizures, they may or may not be able to try this type of brain stimulation. But it involves, working on different parts of the brain to see if the electrical activity can be altered.
What do y'all know about IVIG treatment, whether it's helpful or not? What is it? IVIG is gamma globin infusion.
Yeah,
and it helps shore up your, I can't remember what they're called, immunology.
right, like that there's an immune response. We did a study for Alzheimer's disease using IVIG infusions, and nurses went to the house once a month and did that. And unfortunately, that study was not it was not a positive study. That doesn't mean that in that study it was negative, but it doesn't mean that thought is or theory is over. But I don't know, has it been tested in FTD? Yeah, no, yeah, as far as I know, it hasn't been. Were you talking about anything in particular study? You were just asking.
No, my cognitive neurologist, Dr. Michael Hoffman, got together with my oncologist that I don't have cancer, but my hepatologist, there we go, for the blood. And they thought they had seen a change in me by staying on a continuum. And my IgG numbers still fluctuate, but I feel better and my brain seems to work better. Getting the IVIG on a monthly basis.
Okay, well, that's
And Medicare pays for it.
okay. Well, that's fantastic.
I read quite a big study on FTD, and the research said that one of the main symptoms between all types of FTD was restlessness. And I haven't seen that today on any of your lists or talked about. But I think that the hard thing is most lay people see it as anxiety or something along that line. Unless you experience it, it's completely different from that. But I'm wondering why that's not mentioned at all.
I think sometimes it is thought about, especially when somebody walks around a lot, and sometimes that can be a way to act on it. And so
Why don't they use that? You know, I think that family members don't understand it, and it's not listed as one of the main symptoms. Today, anyway, it wasn't.
yeah, and I think there. And that can sometimes almost be a healthy way to feel better, or to at least start addressing this symptom, is to get up and walk around. So I think sometimes probably in your groups, I would think sometimes it may come up.
Yeah. So it can range. It can be kind of a healthy outlet, but it can become a problem where people have a nonstop need to keep moving to the point where they're kind of ready to fall over, but they keep moving, or they families have to follow their loved one around in a car because they just, or take turns with the walking because they can't
Well, I know another thing for me is I can't sleep. If I have that restlessness at night.
Yeah. Oh, you're up at night. Oh, I'm sorry. Yeah. Yeah. It's definitely a symptom, and I'm sorry we didn't bring that up clearly enough, because it is, even in doctors' offices, people sometimes have the need to move around, or, sometimes that need to move can cause some problems, some safety problems, where people, have a tendency to walk in and out of traffic, this kind of thing, and sometimes facilities are a little bit of a safer place because the moving can be monitored. But I'm sure it's very unpleasant. So, not everybody has every symptom, but that's not an uncommon symptom, the restlessness. And I'm sorry you can't sleep. I don't know, is there anything that could be done?
I'm on a medication.
Okay.
It took a long time. I've had insomnia forever, and I think that's another symptom. But they put me on Requip, and I take that 2 hours before bedtime, and then I can sleep through the night.
All right, well, good. Good. That's wonderful.
Marianne, if I could just say, you have a group of people with FTD here. It'd be interesting just to find out how many people here do have the restlessness.
Restlessness.
Okay. No. What?
It's a feeling like you want to crawl out of your skin, and you just sit.
You want to walk, you can't sit.
Yeah, well, even when sometimes walking helps, but you just sit in your chair. It's a horrible feeling. It is. Or at night, I'll sit in bed and just roll. Because you just got this restlessness that you can't really sleep, so you just roll in bed and roll in bed. Finally, I just get up for a couple hours until I go away and then go back to bed. But now I'm on Requip, and that calms it down. What's that? How often do you have the when I have it at night, it was almost every night. Now, since I've been on Requip, it happens to me maybe 3 or 4 times a month.
I have another question. I've heard about all the research and everything that's happening, and it's really exciting. However, many of us that have FTD, it took us years and years to get a diagnosis, or many doctors. And then finding doctors that knew what the heck they were talking about was horrible. Are we putting, I know FTD is trying to reach out and educate neurologists, although they don't always want to listen, and Dementia Action Alliance and Dementia Alliance International, and they're trying to reach out to doctors, but through the researches and through the medical field, is anybody trying to educate these doctors so that we don't have to go through this? I mean, I know the doctors don't know all the things we heard today. At least I haven't found one. So sometimes they don't even know what studies to do. They don't know what tests to do. What efforts are being made to educate the doctors, if any?
So one thing was UCSF, which has done a lot of work on FTD. They got a multi-million, like tens of millions of dollar grant, I think maybe from a family, but they got a big grant for education. And they are actually trying to educate professional providers around the world. So that's, I think, hopefully we'll start, reaping that benefit soon. But they are really doing a concerted effort to get the word out. There is a lot more awareness, I think, now in medical schools, for example. But yeah, it's we keep trying to make sure that the word gets out, and that is a big burden to ask for you guys to be ambassadors. But I guess all of us are trying to raise the awareness, and at least to put it as, this may or may not be FTD, but at least to have it be part of the question. As easily as people ask, is this Alzheimer's? Well, the next question should be, is this FTD?
I do think that the interest with younger, newer doctors, at these scientific meetings are growing every 2 years. First there was just one small room of people, and now when you say that the meetings are growing, there is greater interest. We are, certainly not doing the best job, but awareness is so much better than it was even, 5 years ago. We were talking before in the research with grants and interests and projects that young scientists are becoming much more interested, right? Do you want to say?
Absolutely,
Yeah.
absolutely. We are seeing a big increase in our applications for pilot grants and our applications for postdoc fellowships, and these are the people who are just starting off in their research careers, so they're definitely aware and interested.
And I guess I wanted to thank you guys as well. If you go to a teaching hospital, for example, and there's a resident or a medical student, it often just takes one visit, and that person will have learned and will become interested. So really thank you if you're open to letting a young physician or a young speech pathologist, somebody who's still learning about different diseases, if they can speak with you and learn more about it, it'll make a huge difference.
Take literature with you. So I'm going to change the direction a bit. So I was diagnosed 3 years ago. The symptoms were there at least 2 years before, more than that. So when am I going to die?
Well, nobody knows the answer for that for anybody. And I think that's what's hard and can be scary when you look at the numbers, 7 to 10 years. But, you keep thinking back, well, when did things really start? And everybody's different. And there are so many different factors that go into determining anyone's lifespan. And if anything, it means it's all the more important to keep up on your general medical health. Because having diabetes, having high blood pressure, that all can affect your brain too. And so nobody knows.
Nobody knows.
Yeah.
Right, that's the truth. And yeah, That I think when you get this diagnosis, you ask good questions but get very vague, or answers that are non-specific, which is another way to say vague. But the reality is that's the truth as we know it right now.
I have to wonder how many people out there have it and don't know it, because I got all kinds of things, but then my mother was put in a research study at the University of Utah, and they found she did have FTD, and they actually have social workers and everything up there. But then, I knew what I had because it runs in the family. But I think if she hadn't gone through that study, I'd probably still think, I'm trying to think what they called it, something dementia. Anyway, we get all kinds of different diagnoses until you finally hit it right. You have to get the right doctor.
Right.
Yeah, and I think also, as we've been hearing today, everybody's disease experience is different, and it can be different at different years for the same person. Maybe for a few years you'll be feeling very restless, but then maybe there'll be a period of time when that's not happening, and so that's what can be difficult, but also hopeful. And so when we think about the pace of a disease, I often think, well, what was happening the past 2 years? Well, maybe that gives us a sense of how the pace of the next couple years will go. And so it keeps being iterative, but it ends up being very personal.
Okay, I forgot what I was going to say. Hang on. This happens all the time. Okay, so what I heard, and I already have this answer, of course, is that you just told me that I'm going to die someday. But I already knew that, right? Everybody knows that. So I've kind of come to the place where I've realized we need to plan as though maybe 5 years, I don't know, but it could be 20. So really, I'm in no different place than I was before the diagnosis, except that the veil of denial got torn away, and now I can say, okay, every day I'm reminded I'm going to die, whereas most people don't have to deal with that, and that's a good thing. But yeah, we're all going to die, right? I used to get mad when people said that, but now I've embraced it.
My mother, FTD, is 84, still alive and doing well. Healthy.
There you go.
She was diagnosed 3 years ago. But we've known she's had it since her 40s, so her personality changed really young. So it just took a long time. Oh, they said she had all kinds of different things, and then they finally got her in a research study that did every kind of brain scan you can think of, and they could show that it was completely FTD. But then we realized her father had it. He died of an accident at 81 years old, so.
We were just speaking about diagnosis and having a long time before most people get a diagnosis. I don't have FTD. I'm here with my mom, and she was just diagnosed a year ago, and she had noticed symptoms probably 6 months prior. And we're in St. Paul, Minnesota, and Dr. Holmes is is her neurologist, and she was diagnosed within that 6 months, like immediately, and has been down at Rochester Mayo and doing work with them. So it is definitely about getting the right doctor and finding the right person, because we have a different story as far as not having a long period before being diagnosed.
It sort of depends on the type of FTD as well. So.
If nobody else has a question, we were talking some about treatments, and I know there aren't any currently, which makes people fairly desperate sometimes, and there's a lot of claims out there. Generally, people say they could be a variety of herbal or different treatments, that they're mostly harmless, but do you know of anything that is just acutely dangerous that people should be aware of and stay away from?
There are some concerns about some of these stem cell treatments. They can be very expensive, but there can also be some danger associated with these injections that can kill you. So that is one I think that I would be very cautious about.
There was a new thing out that was just put out, and I was actually looking at doing it, called young plasmapheresis, which is where you take a young person's plasma, like my kids who are healthy, and they basically draw plasma off of them and then inject it into me, and it tricks your brain into thinking that you're young. And it's actually just, the FDA just put a big warning out to say it's actually very dangerous to do young plasma exchange. So that's one that you may hear on some of these websites about cures. So just be very cautious. I think a couple of the things that have in the complementary world, and you guys can add to this, is some of the things that have shown to be helpful, not harmful, is supplements such as like CoQ10 and high dose omegas and vitamin B6 and things like that that are shown to be probably helpful but not harmful. And I don't know if you can comment on some of the complementary medicines. And I know in Colorado, you know, I have been drug tested for years. I've been a nurse practitioner, but everybody's like, oh, smoke some weed and do some you know, and I'm like, no, because that would keep me out of a formal study when the time comes. So you may comment on the prerequisites for interventional trials too, about if you've done this, you may be opted out of a study if you've done some of these things. So I don't know if you have comments about that.
Yeah, there's a few different points there, and thank you for the plasmapheresis comment. Starting from the end, so it is something to think about when you enroll in a clinical trial. And this is when they're giving you an intervention. Each trial has different criteria, and so it's not a reflection of you. It's just they have to be so careful in order to be able to interpret the results that they're often quite restrictive. If you need to be taking medications for other conditions, they may not want to worry about the interaction. And a different part is that if you enroll in an interventional trial, sometimes it may mean that you cannot do another interventional trial later. And it would depend. An important thing to ask about would be, will I learn after the trial is done if I was given the investigational medicine or not? Because if you were in the placebo group, you were not exposed to the drug, and so you could still go on to participate in different trials. It's always important to, let everyone know all the different supplements you're taking, even if they're not prescribed. Sometimes large doses can be dangerous. So, for example, vitamin D, we're learning more and more that that's important for brain health, but too much vitamin D can be toxic. It's always good just to, not only say these are what I'm taking, but these are the doses I'm taking. And for example, vitamin D, your primary care doctor can measure the level in your blood and make sure that you're not taking too much. There also, we think about, sometimes it can be overwhelming to keep track of so many different supplements and pills. And so that's why it is also sometimes good to go through every single one, think about the cost of every single one, and is this the right thing for me right now? And to make sure that other medicines aren't being pushed out of the way for supplements that we're not as sure about. I'm trying to think if I got through. Yeah, so omegas and coenzyme Q10, yeah, those are probably fine. I mean, it's great also to eat fish itself. But what, often we think about, is there anything that would be bad about taking it? If there's nothing bad, I mean, those omegas can be really big to swallow. So that is something to think about. Marijuana, that, there's many different strains of it, and then there are certain states where it is legal, and a lot of it is just be cautious. Depending on with trials, if you're eligible or not, depending on whether you're taking these. Again, sometimes they would do blood tests to see if it still is active in your blood. But again, everybody is different, and I think part of the caution is if something isn't monitored by the FDA, we can't be sure about all of the contents, and so that is where there could potentially be some safety questions. But the best thing would really be to make sure that somebody in one of your treating providers has really looked through everything and thought with you about, is this something that's good to continue? And I guess, I just I already mentioned, but also thinking about the cost of each one, and maybe it'd be nice to actually spend that money on a really wonderful vacation, or like what would be the best way to be spending the money. But again, everybody's different, and some people might find that something seems to be helpful. What is frustrating is we only have one of each of us. We don't have a clone that we can say, oh, we don't know if you had taken this pill, could it have kept things steady? So there's a lot of unanswered questions, and a lot of it is just making sure we're not doing anything that's potentially harmful.
Thank you. If I could build on what he was saying, I know a number of people with different forms of dementia who have used medical marijuana or not medically approved marijuana, and they say it helps them so much. And I actually saw someone who had aphasia so bad you couldn't understand her at all. What she wrote, you couldn't understand. It made no sense. And she started on medical marijuana, and she's totally different. So my question is, are there studies done on the impact of marijuana and how it helps? I know people that have like the shakes really bad, and it tends to, or agitation, and it really does seem to help. So how much, is there any research in that area?
So yeah, unfortunately, because of federal laws, there can be no federally funded, or it'd be pretty tough to get funding to do this careful research, which is too bad. That's why it is sort of left to word of mouth and where it's legal, and again, controlling for what's the best type for each person. I guess something to be cautious about is that it can slow your thinking, and it can make someone sleepy. So you would want to be cautious about the situation in which you're taking it. And again, everybody's brain at different stages reacts differently, even because there are different cannabinoids which are not supposed to slow your thinking as much. But as with most medications, you always want to see what's the smallest dose possible. And again, everybody's brain is different.
Okay. Can you speak louder? They're having trouble hearing you.
Sure, sorry.
I'm not sure your mic is on.
I think I need to press it right to my mouth and then.
Eat it.
So I think we have maybe time for one more question.
Anyone have a question written that they would like to have answered?
Okay. Is this good?
This is
Okay.
good, yeah.
Okay, so my mom, her name is Barbara, and she's down in Florida in Deerfield Beach, and she's 91, and I have 5 older brothers and 2 older sisters, and I'm the youngest. So that's good. And I have 4 lefties. My brother was ambidextrous, and then they have 3 righties. And my father was a lefty. So that's good.
Yeah. Thank you.
That's it.
Not interesting? No, I think we'll wrap it up.
Thank you.
Thank you guys so much for doing this.